In child psychiatry in India, genetic basis is not discussed at all.
When we are looking at the two parents, they are slightly closer to the median of the bell curve. And when we are looking at a child, he's usually on the more extreme side compared to either of the parents.
Monoamine theory. How can that be really main scientific theory in 2025? It is impossible. Brain is not a neurotransmitter suit. Brain has 2000 neurotransmitter or more. Standing there, basing brain and thinking brain on just few neurotransmitter, 5 namely, and thinking that this is the whole of brain is very, very childish.
I would say that in psychiatry, we are in now that kind of a zone where we can do theoretical psychiatry. We can imagine, okay, what kind of mutations this person has, what kind of cellular processes these mutations would change, and if these cellular processes change, what does it change about the cell functioning, what does the group of cells change, and then what does the organ as well as organism change.
In child psychiatry, how your genetic understanding is coming to play in your everyday.
Just like height is genetic, what I've now started realizing is basically most of our physical features, whether it's the shape of your nose, hairline, or jawline, all of these give us some information about the dysmorphology.
Have you seen the genetic test changing your treatment approach to patient?
A patient with the same symptoms coming to me, coming to some other doctor, he would get different diagnosis.
You are going to do your MD again. What would you do that you haven't done in your MD?
Right now in psychiatry, we are in that kind of a phase that no matter what patient it is, we are able to help them to a certain extent, and a lot of people to a huge extent.
In psychiatry, the main problem is we don't question anything.
There's a huge chance that there's going to be some kind of a genetic issue.
How they should approach psychiatry as a subject.
A lot of people get genetic tests done, but
Hello everyone. This is another episode where we have a relatively junior consultant with us. This is Dr. Ritwick Chatterjee. He has done his MD as well as PDF in child psychiatry from Nair Hospital, and he is now 5 years post his last degree. He is practicing for last 5 years. And we would be talking with him about the difference he is seeing while doing MD and while after MD in how to approach the patient, in how to treat the patient, and in how to understand what is happening to patient. What is missing in MD curriculum that he would like to rectify. So with this, my first question to Dr. Ritwick Chatterjee would be, how you are finding your post PDF practice experience compared to what you learned in PDF and MD?
I would say it's completely different because when we were doing our MDs, at that time, I would say the understanding about what we are treating was not as great. It might also be that we were not exposed to a lot of neurological concepts, but there was basically the classical thing of finding a set of symptoms, matching it with the diagnosis, and matching the diagnosis with a treatment. And because of this, you would see psychosis, you would give antipsychotics, you would look at someone with a history of mania and you would give anti-epileptics. Now, this practice has completely changed for me. I would say that right now I am no longer limited by that viewpoint, and maybe it's more of a personal opinion, I would say. But when we talk about things like, say, depression, anxiety, first of all, those are English terms, so there's no actual objective definition to it. The second thing is it's not brain based, so we are just calling it some kind of a
Hmm.
feeling, which is possibly the closest thing we have in subjective point of view. But when it comes to actually from understanding about the brain point of view, it changes.
Hmm.
And when it changes, then when you're not limited by this exact thing, that okay, this is the clear boundary between depression and anxiety, then you start thinking, okay, what do I do for someone who is in between? So I would say that one of the earliest thing that happened to me after this was that once I started practicing, I started noticing that most patients had a mix of a few things. So some obsessive traits, something like anxiety, something like depression, some level of paranoia. So all of these things were there, and like uh, MD or even the fellowship would not prepare you for these kind of cases, because what do I do? Do I give him an antipsychotic? Do I give him a mood stabilizer? Do I give him an antidepressant, anti anxiety? So in this kind of a picture, I would say you start really thinking that okay, what are my options? Because no longer can I look at DSM, ICD, say APA guidelines or Maudsley, and think okay, this is what I need to do, because this patient doesn't really fit exactly in any exact place. So this was, I would say, the earliest learning that I saw, uh, to realize that okay, first of all, that most patients will not fit into a category. And I would say the second thing would be that so a patient with the same symptoms coming to me, coming to some other doctor, he would get different diagnosis. Somebody will say that okay, this guy has psychosis. Somebody will say okay, no, this is actually a case of autism and he's just disturbed. And for me it became potato at one point because I was thinking okay, even if we are calling it this or that, the treatment is not really changing, so why should I really care about the labels?
Exactly.
So we, like, at least from my point of view, I started looking at things that okay, if a person has these kind of symptoms, if we give this kind of a medicine, what is the kind of effect that I'm expecting on the brain? And yeah, I would say it surprises you because in MD or residency, you would not really catch these kind of patients, but I'm seeing them everywhere in private, where, for example, we give benzodiazepines to calm someone down. Now, there are a few subsets of patients when they take benzodiazepines, they become extremely aggressive. Right? Had no exposure to this concept before
Hmm.
going into private, and I actually got very stumped that okay, like this is completely opposite of what the book is saying. It's not even say it's a mix of something or the other. This response is not something I can see in a lot of places. Maybe there are a few case histories, but yeah, not a very good large number of reviews about it. So how do I look at it from that perspective? So should I give another benzodiazepine or not? Should I try something else? And I would say the understanding of molecular basis of how our medicines work, that was able to give me answers here. It was able to let me think, okay, maybe the issue here is there is a sudden hyperactivity of the brain. Now I need to look at what are the things which slow down the um, neuronal conductivity or speed.
Hmm.
And there I'm looking at benzodiazepine, but also something like antipsychotic, also maybe anti-epileptics. There would be other medicines as well. So suddenly my options opened. And otherwise, in these kind of cases, what I would or what I would usually see in our hospital was that people would just give up, that okay, nahi ho raha hai. This is going to be a very tough case. either we refer it to someone else or we just say that it's a resistance case. So this was, I would say, another chief learning that I had.
Now, you are exclusively practicing child psychiatry, and in child psychiatry, how your genetic understanding is coming to play in your everyday patients. Because in child psychiatry in India, genetic basis is not discussed at all. In child psychiatry, you never learn that this patient might be this syndrome, this patient might be this syndrome. You are taught to deal with the psychological aspect, the behavioral aspect, the various uh, part of working in a team of sociologists, psychologists, special educator, and other thing. But the core of the disease, how the disease is forming, is not taught in child psychiatry anywhere in India. So, standing that, while you are practicing exclusive child psychiatry, how you would say that your genetic understanding is helping here?
I would say, first of all, it's a huge amount of help. The second part is I would definitely say that understanding genetics, now I realize why child is also much more of a challenge compared to when we are looking at most adults or even in geriatric patients. Uh, like, I don't know, maybe it's a very basic concept, but since we have started surviving because of medical technology, so all the genetic mutations are being passed on. And I always tell the parents that, okay, your child is getting half his subset from your side, half his subset from the other parent side, but the enzyme which copies it, it's not a perfect enzyme. It's going to make some amount of errors, maybe a few million base pairs, but it's still going to make some errors. And these errors are basically what he's carrying, which are something extra which neither of you had. And because of this, there would be a higher chance of him having a more severe, I would say, symptom if he's showing a symptom. Like, I like to think of it from a bell curve point of view, that when we are looking at the two parents, they are slightly closer to the median of the bell curve. And when we are looking at a child, he's usually on the more extreme side compared to either of the parents.
Hmm.
It's very rarely that we see that, okay, the child is more well balanced and the uh, parents are that way. The other thing I would say that really helped was understanding that, okay, these genetics are coming from one of the parents, maybe. So we should be looking for clustering of similar symptoms in that parent's side of the family. And once you start seeing that, it gives you a better way to explain it to the patients. So basically, what I usually tell, for example, a child who has come to me with severe level of attention deficit, extremely impulsive, extremely hyperactive, uh, he's not really scoring well in class. Dad keeps hitting him. Mom is frustrated that he's not able to do anything despite him being extremely smart. So usually we'll see that one of the parents will have similar traits. And what I usually do is I tell the parent who has those traits, because if we again, to differentiate how I used to do it before my private practice, it would be that I would tell them, okay, these are the symptoms that the child has, and these are the possible options we have for treatment, and you should pick it. Now, when this happens, one of the common reactions from the parent is कि हमारे टाइम पे तो होता ही नहीं था. This was never uh, any case in our times. So I used to explain to them at that time ki, okay, think about it in your standard. There would always be one child who would have been very intelligent, had a huge potential, but he would not be really into studies. He would be into other things instead. And in the future, right now, he's not really doing well. He's struggling. So a few parents would understand why that. But there are these stubborn parents who would not say at all that there's no way, ये मस्ती तो लोग करती ही हैं, बच्चे करने वाले हैं, why are we calling it a disease? We did not have this disease in our times. So what changed now is when I see a parent with those traits, I explained to them that, okay, because of these issues, you were also someone who had underperformed when you were giving your exams. You had struggled to a lot of places where people kept telling you, okay, you have a huge amount of potential, but you're not performing. And you could never understand what you could do to make it better. So, what I'm trying to explain to you is that your child has this same issue in a more extreme manner. But the good part is that at that time, we were not aware of different treatment options for it. Right now, he will not have to suffer for all the issues that you had to suffer. If we don't give him treatment, he's going to possibly suffer more issues compared to yours. But if we do, that becomes a preventable problem. So that is something which is extremely receptive for most parents, because if nothing else, they are able to kind of explain themselves about it via their own sufferings that they've gone through. And basically, what I keep telling most parents is that right now in psychiatry, we are in that kind of a phase that no matter what patient it is, we are able to help them to a certain extent, and a lot of people to a huge extent. So, this was also a huge change.
How much genetic test you prescribe, and have you seen the genetic test changing your treatment approach to patient?
Definitely, I would say that this is coming from me not having a very huge background in genetics, and I am just understanding genetics. I'm just a student of genetics as of now. So, me being a practitioner at Pune, we do tend to have patients who tend to show clear cut issues, and where there's a huge chance that there's going to be some kind of a genetic issue. Then there's also phenotyping. So nowadays there are apps like Face to Gene. So I've been using those as well. But genetic testing obviously is much more accurate. And I would say that in a few of those patients, definitely we were able to change the treatment based on the like genetic tests that came up. And interestingly, the issue was that the interpretation of the genetic test was not being done properly. A lot of people get genetic tests done, but matching the genetic test results to the actual phenotype that the patient has, that I would say is the tricky part. And this is probably where most of us are failing. But if we are able to find something like that, yes, it does change treatment quite a bit.
So, how is your phenotype analysis going on? You are interested in psychiatric dysmorphology. So, how you are trying with psychiatric dysmorphology?
So, basically, I'll explain this to how I explain it to my patients.
Yes.
So, what I tell them is ki, uh, when you were born, all the cells of your body are coming from that first initial cell, which is that zygote, and it's now dividing into different cells. And because it's dividing into different cells, different uh, like structures are being formed. And because of some mutation or variation in the genetics, these structures can get formed in a slightly different manner than others. And one of the common examples I give them is like if you take height. So we know that if two tall people tend to have a child, he'll have usually a child who are either taller or at least of a similar tall height. But very rarely would you see two tall parents have a very short child. So just like height is genetic, what I've now started realizing is basically most of our physical features, whether it's the shape of your nose, hairline, shape of your orbits, or jawline, dentition, all of these give us some information about the dysmorphology. And these are very fine changes. And because they are so fine, it doesn't really come under what we call as the syndromic phases.
Yes.
So we are looking at way more finer dysmorphological profiles compared to what I would say a pediatrician at a much younger age would see. But I would say that it has helped a huge bit in identifying the patient's symptoms without me having to ask them a lot of times. A lot of times you are faced in a situation where the child is possibly not verbal, or maybe the parents are from a slightly lower understanding or socioeconomic class, and they're not able to tell you in depth about everything. So this becomes a extra way of understanding, okay, these are the possible traits or genetic traits that this patient has, and the treatment also changes based on that. Sometimes I get another, I would say, very interesting thing which has happened is, uh, once you understand this kind of a dysmorphology as well as genetic basis, you are able to predict the symptoms of the patient to a certain extent. So that is something I feel is extremely nice. I really enjoy that part of the dysmorphology where I don't let the patient speak. I ask him, okay, let me explain a few things and let me understand whether I've predicted it correctly or not. So that also helps the patient have more trust in you.
Rapport building is good.
Yeah. And the other thing is that they are definitely much more open to medications once they see this level of expertise. So, yeah, it's something which I find very fascinating. But I will also say that it's also, the more I'm getting into it, I think I've been now doing it for like 3 or 4 years. And the more I'm getting into it, the more complex now it seems to me. But yeah, definitely there's a huge amount of treatment options that change if you do phenotyping like that.
Exactly. So we should be more interested in reading Smith's book of recognizable human malformation. We should read the bedside dysmorphologist. We should read the books on dysmorphology, because dysmorphology proper would give rise to the psychiatric dysmorphology. Psychiatry has a very nice dysmorphology in its clinical genetics profile. Unfortunately, very few people are interested in it, and less than probably few are actively doing it. But it has the ability to change psychiatric treatment by a large. So that is why psychiatric dysmorphology is important. You have actually focused on a very good line. Now, let's say today you are going to do your MD again. What would you do that you haven't done in your MD?
I would say, first of all, like not just MD, but even in MBBS, we were never really exposed to a lot of genetics. Even in MBBS, you would read about genetics when you're reading about a specific disorder, few genes that you'll have to remember. That's about it. We were taught embryology in our first year, which was, I would say, severely underscored, because
Yes.
we need to understand the developmental profile of the brain, the developmental trajectory of the brain, not just, I would say, in child, but also for an adult, and also for how the person goes till, I would say, old age. A classic example is like those patients with Down syndrome,
Yes.
where we see a very clear cut early neurodegeneration. So that is what I would say, that this developmental trajectories is not something we understand at all. This is very important. Second part is, I would have focused much more on embryology and genetics of the embryology part. Third thing I would say would be understanding how meds are working at a cellular level. Now, this might be a bit out there, but basically, like, I've been a big fan of science in many ways. So, like, one of the sciences I love a lot is physics. So back in around 1850s, or say early 1900s, there was this situation where, uh, when Einstein had not become very popular, at that time people were basically talking about physics as, okay, that we have now observed most of the things in our environment, and there's very few new changes which are going to come up. And that is why people used to go for other fields rather than for physics. And what interesting thing that Einstein did was he went into what we call as thought experiments. He would just sit there, and one of the, I would say, favorite experiments of his was imagining a person falling. And instead of thinking about time and space differently, he would think of it together. So he would imagine what the effect of it would be, what else it could be. So that's when theoretical physics came into existence. He predicted something like black holes with that, and the proof of which we saw maybe 100 years later now.
Yes.
So I would say that in psychiatry we are in now that kind of a zone where we can do theoretical psychiatry. We can imagine, okay, what kind of say mutations this person has, what kind of cellular processes these mutations would change, and if these cellular processes change, what does it change about the cell functioning, what does the group of cells change, and then what does the organ as well as organism change. So this kind of a paradigm shift is now possible, I would say. uh, in my MD years, it was not something I could have imagined, but now it makes much more sense for me to actually run it in my head, find out this first, and then match it with the patient profile. That way I'm running different simulations in my head that may come up for other patients. Yeah, so this is something I would say I would probably focus on these. I would not focus so much on the psychological aspects or the DSM or the ICD part, mainly because for me, what I saw after practice is that uh, it doesn't matter what label you're giving to the patient, the treatment doesn't change. If you understand genetics better, the treatment is going to be a genetic based treatment, not so much focused on only the current symptom, but also the
Longitudinal.
developmental trajectory. So, if a person is able to understand this and treat patients with this, so what I would say I regret is not having this concept in my head in my first year. If I did, then I would have probably changed a lot of treatment protocols when I was treating my patients. I would have experimented more. I distinctly remember in my residency there were at least, I would not say a lot, but there were maybe 5 or 10 incidences where so I remember one case where the patient was um, severely depressed, and along with severe depression he had given one symptom of that, okay, I sometimes feel that if I'm going outside, people are looking at me and they're spitting in close to me. So my registrar at that time, listening to this, had changed the treatment to only antipsychotic based on the diagnosis of psychosis. For me, I was very sure that this is a case of depression. The You could maybe call it depression with psychotic features, but it was not psychosis. And this guy needed antidepressants. And honestly, I had started him on antidepressants first. He had gotten better, but when the senior had reviewed, he just took everything off and just put him on antipsychotics. His mother was working, so they wanted an early discharge. They discharged him within a week, went ahead and committed suicide. So already made me question that, okay, what could I have done? Should I have had this fight with my senior at that time? But again, based on what what could I tell to the senior that मेरे को feel हो रहा है इसलिए. So now I have the understanding to be able to say, okay, this is the reason why I feel that you should be going ahead with this treatment. So these kind of experiences, I think, is common for almost everyone.
All of us.
And till this point, I didn't really have a way to explain it to other people and sound logical and scientific. It would be more on gut feeling.
Hmm.
And gut feeling is not something I would say that anyone should follow when you're treating patients.
Exactly.
So once I have this kind of a thing, at least it lets me explain in a more scientific, rational manner to the person. Uh, But again, it depends on the scientific understanding of the person that you're talking to as well. So there are mixed things results to that. But overall, I would say that these are the places I would focus on more.
And what you would like to tell to the students who are going to listen to this podcast? What they should do in their MD, what they should not do in their MD, and how they should approach psychiatry as a subject.
I think one of the earliest lessons I learned in science was trust no one and don't even trust yourself, trust no data until you have cross checked, and cross checked. And there is this, I would say, level of commitment that we see, say, someone in core maths, core physics, or core chemistry show to their subjects, and we don't. We just take people's word for it. And nowadays, even in psychiatry, a lot of studies are being replicated, and we're not seeing the same results as the people who used to do those studies.
Hmm.
We are now started to think, has the data been manipulated? So we are facing a lot of places where we have a lot of uncertainties. So I would say the most important thing would be to question everything within logical limits. And uh, if there is something happening, there has to be a logical reasoning behind it. There has to be a biological basis behind it. It should be something which should be measurable. So if you can just think from this way, matlab, it's not a very, I would say, weird request. I would just say that treat psychiatry more as a science, and go back to how you used to question everything when you were in high school or college, when we used to have that level of critical thinking and people around us who would help us question. Even right now, if someone questions, okay, what is light? Is it a wave or a particle? The answer is going to be very different now compared to what it was, say, many years ago. But basically, we are no longer taking only someone's word for it. And in psychiatry, whatever the issue is, we have a huge legacy, 100 years of legacy of maybe poor understanding about what the brain is. And not our fault, because we didn't really have advanced imaging or genetic testing available to us for a very long period of time. We are now starting to finally get there. I am still not happy with the level of, I would say, functional imaging that we are able to see, because uh, it gives us a resolution in about milliseconds and microns. And I would like to know now within maybe nanometers or within maybe nanoseconds, because that's the kind of activity we are looking at.
Hmm.
So thinking with an open mind, questioning most of the concept that you're seeing, cross checking everything, and always remembering that whatever is happening, there has to be a scientific logical reasoning behind it, and there's going to be a biological basis behind it. If we can just try to find that out, we should be able to find out a lot of things. uh, yeah, I would say, from a practice perspective, these are the things that I would recommend the most.
And along with any change we can do to psychiatry syllabus that would bring out more science in psychiatrist. Yes, it is a wishful thinking because neither you nor me have power enough to do that. But if we want to change, what can we change?
I think first thing I would want is probably the teachers to start questioning more. I would say I was pretty lucky in the way that I got my guides, as well as seniors and teachers in my college. It was one of the best departments out there, and a lot of them used to ask us questions. It started off well. It started off with this kind of a feeling that, okay, let us question about this. Why this medicine? Why not this medicine? Why this disorder? Why not this disorder? Uh, so that was the feeling I had in the very beginning of my first year. That did not last for more than a couple of months, because then I got senior residents, were basically not really encouraging of questions. uh, who were saying, okay, बोला है तो करना, क्यों सोच रहा है? The other thing I would say that I would like to change would be the curriculum. Way more emphasis on the understanding about genetics. uh, Definitely a huge module needed for embryogenesis of the brain. Developmental trajectories need to be understood and respected, which we don't. And again, not to be restricted by DSM and ICD when you're treating. Otherwise, there are some wonderful medicines that you don't even ever discover. Propranolol, for example, was one of those medicines for me. Never really used it much during my MD years or post MD years, but once I started private practice, I could definitely say that it's there in probably 70 to 80% of my prescriptions. So, and it's a wonderful drug. It takes away the need for a lot of benzodiazepines, no dependency on them, no drowsiness during the day. So, there are gems like these that we miss out because we are not open minded enough about questioning, okay, can I use something else in this instead of this? Never really asked myself this question, okay, why propranolol? Why not something like carvedilol or metoprolol? And now I think of these questions. So I would say that like post MD, I'm going back to how I used to be in my school years. There was that naivety as well as interest in trying to understand why things are working that way and trying to dissect things in that way. And final, I would say, is doing thought experiments in your head. We underestimate the usage of thought experiments. Thought experiments has definitely made me a much better doctor because I've been doing those for at least the tough cases. And there, going through a thought experiment, it gives you way more options that you would never really find out unless you think about it. If a senior tells you, you will not never really understand why he's saying this to you, but if you think it for yourself and you come to the same conclusion and a senior also validates that, it makes much more sense. So, yeah, question everything and keep an open mind. Don't get restricted by the non scientific part that we tend to have. And again, try to go back to the scientific ingenuity you had in your school years as well as college years.
Thank you. Thank you for the detailed answer. I would just add one thing. If your scientific logic is saying this is true, if your scientific understanding is saying this is true, and if your thought experiments are saying this is true, then whether senior approves or not, that is true. So, with this, we are ending this episode. Thanks, Ritik, for coming here, and thanks for saying the encouraging words to the PGTs, because in psychiatry the main problem is we don't question anything. I would just give few examples. Monoamine theory, how can that be really main scientific theory in 2025? It is impossible. Brain is not a neurotransmitter soup. Brain has 2000 neurotransmitter or more. Standing there, basing brain and thinking brain on just few neurotransmitter, five namely, and thinking that this is the whole of brain, is very, very childish. Similarly, clozapine is the gold level drug. Another thing that nobody questions. Why is clozapine gold standard? Because 1988 Kane study. Have anyone replicated that study in today's standard? Where no 60 milligram haloperidol comparison, rather comparison with something else, where comparison is with some new treatment paradigm. Clozapine would definitely fail if we do that. But we dare not question our gods. So it is time in psychiatry to question the long held belief. Belief is not science. Belief is not even anything except just blind faith. And science doesn't work in blind faith. With this, I am ending this podcast and thank you everyone for doing it. Thank you, Conceptual Psychiatry, for giving us this platform.